Dr. Melissa Geraghty's psychotherapeutic style is based on acceptance and commitment therapy and behavior therapy, which incorporates mindfulness, teaching, and coping skills, and assisting clients in their living values. She bases her care on the biopsychosocial spiritual model and therefore views and supports each client as a whole. Dr. Geraghty has an innovative, active style of therapy which involves clients learning about themselves through exercises. I think she is compassionate, funny, and unconditionally accepting of her clients. She's also a pain patient. Please welcome my friend, Dr. G.
Good morning, everyone. Let's put this up a little. Oh, no worries. Thank you all for having me here today. It's an honor to be here and be able to present something that I actually presented at Pain Week, which is the National Conference on Pain for Frontline Professionals. So it is the largest pain conference in the United States. So I am presenting these slides to you today unedited. And I'm really excited about that because oftentimes the general public does not get to see what's presented at medical conferences. So this is in its raw form. All right. I also wanted to do this presentation here specifically to just have everyone in pain feel validated. The stories that are shared in here, I'm sure you have all experienced or may experience in your life. And it's also to allow caregivers and family members and other healthcare professionals to learn better how to communicate with people with pain as well. So let's start with some stereotypes. Sometimes when we think of people with chronic pain, these kind of images come up. However, these are also people with chronic pain. And so I want you throughout this presentation, and just with those photos as well, notice your reactions to the slides, notice any internal biases you might have, or any judgments that come up, and just be aware of that. As healthcare professionals, some biases that we may have can affect our treatment with patients, so it's important that we are aware of these before we go into our sessions. So in no particular order, I'm going to be talking about the etiquette of how to communicate with people in chronic pain. Now, the first several slides are pretty just common knowledge, typical things, but very important still to discuss, and then the slides get more complex as we go. So, of course, first-person labeling, as we know. So, person, patient, client with chronic pain, person with cancer, person with MS. People are not their disabilities, although their disabilities are a large part of their life. Another one is who is the patient. So when a patient comes into the room, two people come in the room, a couple, don't assume who the patient is. You should ask that. Don't assume disability. Also, if a person has a translator, look at the person when you're talking, not at the translator. So who are you? Avoid questions like, who are you without your disability? How might you be different without your disability? What this assumes is that this disability can be separated from us, and we know that it can't be separated. It is a part of who we are, but it is not all of what we are. This is like asking someone, who would you be if you weren't male or black or Jewish? It's the same thing, so don't ask those sort of questions. With terminology, be aware of how you speak to your patient. There's lots of doctors who will label their patients as treatment resistant, and having this certain belief can alter how you communicate and respond with your patient. Many patients, I worked in a hospital setting before, and lots of nurses and doctors would joke about frequent flyers to the emergency room. I'm sure some of you have experienced that label or overheard that label, and this just feels very demeaning and invalidating. With diagnoses, as we know as pain patients, two patients may have the same medical diagnoses but completely different symptoms. So don't affect that it affects everyone in the same way. Make sure to ask questions. Also asking about the disability. Ask questions such as, what is the nature of your disability? Are there ways in which your disability is a part of this presenting problem? Do not ask questions such as, what is wrong with you? What happened? Those can also feel very invalidating. And the little caveat that I have below is, yes, something may have happened to cause the disability, like a car accident or a fall or some sort of injury, but at this point, the point of the session with your patient is to understand how it impacts them now. Understanding. Don't be afraid to say you don't understand something a patient's explaining. We worry as doctors that this will show our ignorance. However, the person will likely be excited that you're showing interest in trying to understand, as they often get that in their general life. Also, if you say you're going to get back to a patient after researching something or saying you're going to look up something that you're not aware of, follow through with that and make sure to facilitate that communication. Provide compassion and dignity, not pity. This is a big one. I have nothing else to say about it because it's something that I really encourage medical doctors and other healthcare professionals to do. Sitting with difficult thoughts and feelings. So as caregivers, as fellow pain patients, as healthcare professionals, we don't always have to have the right things to say when someone is talking to us about their chronic pain. But what we can do is listen and sit with them while they're talking about their pain. Most people turn away from doing this and actually sitting through difficult thoughts and feelings because it can remind them of their own mortality. They can't comprehend how a person can be in so much pain and still semi-functioning. So they often will go to kind of quick caring fixes, such as, it will get better, or it could be worse. And as pain patients, that's very invalidating to hear. We don't want you to try to fix us. We want you to listen to what we're saying. Assistive devices. Do not touch someone's assistive device, whether it's a wheelchair or cane, without permission. This can be seen as invasion of personal space, and the same goes for therapy dogs or service dogs. Do not pet these dogs without the owner's permission first. Giving physical help. Do not assume a person needs help, and do not start helping them without asking first. So use your judgment on if you should help or not, and ask. Another obvious one, making your office accessible. A lot of people, when you're going about your day in your office, you might just think, oh, I can get around just fine, but really go back and check, okay, do I need to move filing cabinets or chairs in a certain way that it is accessible? And the little things, I find this an important one. So it's important to affirm the little things that might seem little to you, but is really a big deal for a person with pain. Such as the example here is, you were able to sit for 5 minutes and do some mindful breathing after that painful day. Awesome, great job. That might seem little to someone who doesn't have chronic pain, but for us to be able to do something for ourselves and get through the pain episode is monumental and very important. Also, the little things in my office for my patients, I have blankets and pillows and lumbar devices and heated blankets and cold packs. So it's important to be able to make those things accessible. Sharing personal information. So if you're not diagnosed with a chronic medical condition, don't discuss your headaches, aches, pains to your patient in order to show that you understand, because you don't. If you're having a little headache and your patient's coming in with a severe migraine, don't try to compare. That's very invalidating. Also, don't immediately say things like, oh, my best friend has a physical disability. While that may help your credibility later on, timing is everything with that. You don't want to seem too overzealous of, like, yes, I know people with disabilities. No, take your time to get to know the patient. If you do have a physical disability, share it when or if it's appropriate. A lot of my patients say that when I share my difficulties, it really helps them feel validated and understanding and understood and gives them hope. So able-bodied disclosure. If your patient asks how your weekend went and you did a half marathon, don't say you did a half marathon. People with pain hear this all the time in their daily lives of people doing lots of stuff. And that's great if you did a half marathon. But your patient is in your room to get compassion and understanding, and they really don't need to hear more able-bodied disclosures like that. And this goes with the next point as well. So small talk and chit-chat. One of the hardest questions that I personally experience and my patients experience is, how are you today? Is a very hard question. It just is. Because do we take the time to kind of say, oh, I'm, having all this arm issues right now. I feel like I'm gonna faint and have a migraine? Maybe not. So it's kind of about gauging whether, do I say something or not? And so the pain patients often have to really quickly decide, is this a person I can trust or not? So oftentimes we end up saying, oh, I'm great, I'm okay, that's great. So I encourage healthcare providers, instead of maybe asking that question, ask questions such as, it's nice to see you today. What's been going on since the last time I saw you? Sex and intimacy. Do not assume that a person with disabilities cannot have sex or does not enjoy sex. And remembering that sex and intimacy can present differently for people with some disabilities, and that there isn't or shouldn't be a standard. What the standard is what our culture kind of says it should be, but intimacy can be done in very many ways. And also don't be afraid to bring up sex and intimacy with your medical professionals. On the topic of having children, do not make assumptions on whether a person in chronic pain wants or can have children. Many people with chronic pain suffer for days or weeks, even after simply holding a friend's baby. So they might make the decision that having a child was not best for them. So don't follow this up with, well, you can always adopt, or give that pity look, and oh, you don't know what you're missing out. People say these things out of their own discomfort and expectations that people should have children. People who do not have children are also sometimes viewed as not being a real woman, not having a complete and fulfilling life. So if they don't have children, so do not perpetuate this perspective and this type of thinking. Proving one's worth. Many people with disabilities, we feel like we have to consistently prove ourselves, whether that's at work or at home or with friends or to ourselves, because of everything that we're dealing with. And we feel like we have to prove that we're not defective or deficient. And so I talk to medical professionals about not going right into how, oh, that's not healthy thinking, you shouldn't think like that, like you shouldn't have to prove yourself to anyone. Really validate that experience, because that's part of the chronic pain continuum. Body language. Do not assume that everyone has the same body language. So nonverbal cues may be altered by disability. If someone's arms or legs are spasming or slouched, maybe that's not a response that they're disgusted by you. Maybe that's they're having a spasm or something like that. So that can be really easy to misinterpret it. I oftentimes, in couples therapies with my patients, really help them understand body cues. And no, I did not make a facial grimace at you. I'm not trying to start a fight. I'm really just having a lot of pain. And so being able to have that open communication in relationships really helps. So this starts my first clinical case example. So real life examples related to all these sort of things I'm talking about today. And so the first one is an example of a young woman who was in a meeting with her boss and her supervisor. She was listening attentively, she was making appropriate eye contact and taking notes, but she was also seated extremely rigidly and straight at the end of her chair, as that was the only position most comfortable for her in that moment because of her pain. Her boss, midway through the meeting, interrupted, gave her kind of a mean look and said, "It looks like you're anxious and you're just not listening, and that you look like you're about to jump out of the chair and leave." But really, that was not what was going on with this woman's internal experience at all. Effects on cognition. So Dr. Oakland is a psychologist with physical disabilities. I'm going to go ahead and read this quote because I think it's very important. It's from one of her books. "I am not like everyone else. I am the exception. Things don't apply to me. This is a form of narcissism I sense in myself and others with disabilities. We are so used to pushing and shoving our way in, being our own advocates, being on the outskirts, being the exception, being different, that we start to think we are the exception in ways and situations other than those related to disability. Clinicians must understand that this process and not mislabel it as a personality disorder." This is so important, that many clinicians will start to assume that, oh, they're just a narcissistic personality disorder. No, when you live with chronic pain, you're having to, on a daily basis, meet with a lot of battles. Catastrophizing. I don't know about you, but as a pain patient, I don't like this word. It has a lot of different connotations in it, and it's very much a hot topic. And so what I tell medical professionals when they're talking to their patients and they assume, oh, they must be making stuff up or over-exaggerating, I say really question what they're saying. So if a patient comes to you and say, "I felt like I was dying during that pain episode," and maybe the clinician's first response is, "You weren't dying," really ask why they thought that. You're going to find clues to what's going on with them that might further help with treatment and diagnoses, and most important, compassion. The person's saying that for a reason. They're suffering. Listen. Stereotypes. Preconceived stereotypes can influence questions asked by healthcare professionals, and then it can influence their treatment planning, like I stated before. So some examples are anger at oppression or injustice might be misinterpreted as a personality disorder. Of course, as people with chronic pain, we're going to be angry and upset at injustices that we see every day, but that does not mean we have a personality disorder. Strong self-advocacy might be misinterpreted as entitlement, grandiosity, or narcissism. We have to advocate for ourselves. That doesn't mean we're narcissistic or self-centered. The increased vulnerability and mortality one feels when having chronic pain should not be pathologized. And be realistic is what I tell healthcare professionals. For many people with physical disabilities, their conditions might worsen due to age or new medical difficulties, and even if the disability is itself not progressive. So don't present statements such as, "I'm sure we could find a cure soon," or "I'm sure it could not get worse," because you don't know. Here's a collection of just don'ts, part 1, that I have collected over my years of doing this from patients. So do not say or insinuate that other people have it worse than you, so you should be thankful you don't have it as bad as them. Do not say God wanted this to happen to you for a reason, or you should pray harder so your pain can go away. Do not minimize the patient's experience or define away their minority status by saying things such as, all people have handicaps of one type or another. Do not say, you just need to get out of the house more, work out more, go gluten-free, take more vitamins, get more sleep, get a job. Invalidating, right? Do not say, my mother's friend's uncle's second cousin has fibromyalgia and tried these great herbs and teas and it cured him. How many times have we heard the peppermint tea and all this stuff? Like, tired of it, right? Do not say I'm tired too. Everyone is tired. Ooh, that's a hot button one for me. You have no idea what tired is if you do not have chronic pain, right? Do not say you're fatigued. You don't even work full-time or have children. Part 2. Do not say, I have back pain sometimes too. I completely understand what you're going through, because you don't. Do not say, but you look great. Do not say, but you did that cooking or walking or whatever it was yesterday. You can push through it today. We know sometimes we might be able to do something 1 hour and then the next time not be able to do it. Do not say you're way too young to be sick. Well, I'm sorry my disabilities didn't check my ID card because too bad I missed that one. Do not say it must be nice getting to stay home all day. Yeah. Do not say you just need to think more positive. Your pain will go away if you think positive. Do not say you're just depressed and stressed. It's all in your head. Do not say you aren't trying hard enough. Do not say you're taking way too many medications. So lots of just don'ts. I've heard all of these myself, and I'm sure many of you have. So here's a clinical case example of just don'ts. So this one woman was at work one day, and a coworker was interested about her chronic pain and physical disabilities. So she asked her about it. And the person with the disability shared some information. And the coworker said, you should really go to the elders at my church. They would be able to take the physical pain away from you so you can be cleansed. Chronic pain is really a demon or the devil inside of you. So you are probably being punished for something you did. I used to drink, smoke, do illegal drugs, and have lots of premarital sex, but now I am saved, and you can be too. Yeah, that's great. So guess I have the devil in me. Okay. So lazy and crazy. Many people view people with chronic pain as being lazy, pain being all in their head. Validate this experience. You are not lazy. You are not crazy. So living with uncertainty. Do not confuse uncertainty with paranoia. Will my disability get worse? Will there be a ramp at that office? Will I have energy enough to get everything today that I wanted to get done? Will my family think I'm lying or over-exaggerating pain levels because I have to cancel plans again last minute? Will they think I'm canceling for attention? Disability requires a high tolerance for uncertainty, as well as for pain, powerlessness, discrimination, and oppression. It's not pathological. Smiles. A smile does not mean a person is in less pain that day. It means that they are trying to live their life. It means that they are trying to live their values. Never tell a person, oh, you look like you're in less pain because you're smiling. That is so invalidating, and personally and professionally with myself and other patients, this is a huge fear that we have, where many people with chronic pain will get stuck in a cycle of not trying to smile at all because they have a fear that people won't believe them. But at the end of the day, we have to do what's best for ourselves, and if trying to live our values and putting on a smile is something that's good for us, then that's what we should do. Studies and medical trends. This is just like that one that I talked about the uncle's cousin's third sister, whatever. Yeah. So unless if you are asked or you are part of that person's specialty team, please don't bring in here's this diagnosis, and here's this Dr. Oz article, and here's these herbs and stuff, because we've probably already read about all of that, and we'd rather not hear it from another person. We appreciate that you care, and I remind my patients, people are doing that out of compassion because they want to be able to help, but it can feel very invalidating and feeling like something is innately defective with yourself. If all these other people are taking these herbs and they're showing great results, why isn't it working for me? What's wrong with me? So it doesn't feel very good. Invisible disabilities. So understand the impact of both invisible and visible disabilities. Both types are equally distressing. Many people with invisible disabilities feel they have to work harder for people to believe that they are in more pain, so they may have the tendency to verbalize it more. Cancer comparison. I actually wrote an article about this, and I'll be coming out in a couple months. This is a big one, and this is close to my heart. If a patient says, or a family member says, I wish I had cancer instead of chronic pain, do not respond with, you don't mean that. Cancer is very serious. Do not respond with, how can you say that? Many people with chronic pain say they wish they had cancer because there is typically a standard protocol for cancer treatment. There is a chance of remission or full recovery. There is more funding for cancer research, thus more public awareness. And friends, family, and healthcare professionals tend to be more supportive and understanding. One of my internships, I worked at a cancer facility. And many of my cancer patients who had chronic pain prior to having their cancer diagnoses told me that living with cancer is easier because they don't have to feel like people are thinking they're lying or over-exaggerating. So this is a big one. Fatigue. Do not comment on how tired you are unless you can directly relate to the non-restorative sleep or chronic fatigue, and saying this would facilitate a mutual understanding. Here's the thing. As we know, most people are tired because they're able to do things they value, the things they care about. People with chronic pain, we're tired and fatigued as a baseline. There's a difference. So here's a little clinical case example about fatigue. This person said, I was telling my close friend who is pregnant that I was more fatigued than usual this past week, so it was harder for me to work. She responded by saying, welcome to the club. I don't sleep anymore since being pregnant. This felt so invalidating as I haven't had restorative sleep for 10 years, so it was more like welcome to my club. Her sleep deprivation is by choice. Mine is not. I don't know if I should tell her how I felt invalidated or if I should let it go because she's pregnant. I know I get this all the time from other people. She should know better. Negative interactions. So loved ones with healthcare professionals, we're all going to have, as people with chronic pain, negative interactions. And here's one clinical case example. So this is a young woman, and after having really severe migraines that were different from my usual migraines and headaches, I finally got up the courage to go to a new neurologist despite having negative previous experience with one. Because I'm always thorough, I went through all of my physical disabilities so he could understand the bigger picture and what might be contributing to the new types of migraines I was having. Instead, all he heard was my diagnosis of fibromyalgia. He said, as he laughed, do you want to get better? Because those pain clinics are just keeping people sick. Next time your husband gets married, he should marry someone fat and ugly, as that they would be too scared to be sick. I left feeling devastated and furious all at the same time. I was finally reaching out to get help and didn't get any. I was also in disbelief concerning how poorly I was treated. I'm never going to a neurologist again. A couple weeks later, this same woman was diagnosed with cluster headaches, also known as the suicide headache, and that doctor had missed that because of his preconceived notion that fibromyalgia is all in your head. So people with chronic pain will naturally have negative interactions with strangers. Here's another clinical case example. A patient around the age of 18 who had multiple invisible physical disabilities was having an okay pain day, as she put it. So she decided to go to the store and get a gallon of milk. She was very happy to do this as she hadn't been to the store in weeks, and she wanted to save a trip to the store for her parents. While she was getting out of her handicapped parking space, a male stranger started to yell at her, saying, these spots are for people who are disabled. What did you do, steal your grandparents' handicap pass? He kept yelling at her all the way into the store. She got the milk, but was crying the whole time. After purchasing the milk, she sat in her parked car and sobbed. After this incident, the patient questioned if she should walk with more of a limp when she gets out of the car, in hopes of deterring people like this in the future. Here's another clinical case example. A young patient was on a plane getting ready to visit family in another state. She knew the trip would be hard for her condition, so she was prepared. She had pillows and her breathing techniques, as well as a good book to read. The man behind her had a toddler on his lap. One of my biggest fears when I go on the plane, by the way, right? It's like, please don't go behind me, please don't go behind me, right? So the man behind, So while the plane was still at the gate, the toddler kept repeatedly kicking the seat, and hard. So after about 15 or so minutes of this, the patient got up the courage to politely turn around and say, "Excuse me, sir, I'm sorry, but I have a spinal injury and would very much appreciate it if your son would stop kicking the chair. Thank you so much." The man gave the patient a mean look and snapped, "Well, maybe next time he does it, you should turn around and slap him." The patient was scared and tense the whole flight, thinking that this unstable man might do something to harm her. She kept thinking about asking to switch seats, but didn't want to be a burden. Luckily, a flight attendant heard what happened and whispered to the patient that he was going to keep an eye on the man. Here's another one. A patient in their 20s was waiting to be escorted down the ramp to the plane by airport staff member in a wheelchair. When the staff member arrived, he looked surprised and said, "Wow, aren't you a little young to be in the wheelchair?" When on the ramp, where no one else could see, he proceeded to turn the wheelchair around backwards and said, "Do you like roller coasters?" And before the patient could say anything, the staff member proceeded to travel very fast backwards down the bumpy ramp, and this patient's pain and anxiety was elevated the entire flight. Negative interactions with bosses. A patient with multiple disabilities had their pain physician write a note to give to the patient's boss. The note discussed how the patient needed to have her computer screen raised due to her physical disability. Many other people in the office without disabilities already had their screens raised, so the patient didn't think it would be a problem, but she just wanted to get it in writing just in case. After presenting the note to the company's VP, directed by her manager to do so, the VP crumpled up the letter and threw it in the trash in front of her. The VP was frustrated and acted like this was a huge inconvenience. The patient did get her computer screen raised in the end, but was very upset about the incident. Here's another interaction with bosses. A doctoral therapy intern was in a car accident and was experiencing PTSD. She was embarrassed as she had to wear a neck brace to work, and she didn't know how her therapy patients would react. She talked to her supervisor in private about this and the PTSD, and the supervisor later that day nicknamed her Crash in front of all the other therapy interns. In individual supervision later that week, she told the supervisor that she was very hurt by his comment. The supervisor said that she couldn't take a joke. And then he ended up treating her differently than the other interns for the rest of the year. So many patients with chronic pain attend treatment for life, and I tell healthcare providers to normalize this. As we get older, our new diagnoses present, or things kind of shift around. In order to properly take care of ourselves on a biopsychosocial spiritual level, it's important for us to have accessible treatment. This is part two, too. So new disabilities can form from existing disabilities, or new traumas can happen, maybe another car accident or another fall. And this can leave a person feeling like their world has been turned upside down yet again. And people also further gain different perspectives at different points in their life, thus making adjustments to what is important to them in treatment. Needing medication adjustments or trying new treatments such as acupuncture and changes in sleep patterns can also be a continual need for going to appointments. More parts of this is that if a patient spends some time away from treatment because they're doing well, they might feel like they're starting from scratch when they come back. So each time validate that when they're coming back, that is showing self-care and self-advocacy, and that's a good thing. That's not a sign of weakness or defeat. That's advocating for yourself. So here's an example of a patient who felt bad and frustrated that she developed a new condition. A patient came back to see her clinical pain psychologist after months of being on her own. She came back because a new disability occurred after being a passenger in yet another car accident. She was feeling frustrated with the new limitations. The patient said, "Just when I was able to start adjusting to my other limitations, now I have even more. I'm already impaired enough. I'm just so sick of this. I keep thinking back to my past diagnoses, and I know that these new problems will become chronic too. That's just my luck. It's just one thing after another." So misunderstandings, as caregivers or as health professionals or even as pain patients, we will say something that is inevitably viewed as we're not understanding or being invalidating, and that's okay. We are human. Use that to your advantage and ask and learn from the situation. So after all this, take a deep breath and know that we've all done some of these things. Even as chronic pain patients ourselves, we may have misjudged or mislabeled someone else, but then what we can do is learn better and know better from the next time and show ourselves compassion as well as other people compassion. When I was presenting at Pain Week, this is something I made sure to really highlight for the medical doctors as well as other professionals there, is if you're new to the field or you've been in the field for 20 years, you should still get supervision. And if you are an able-bodied healthcare professional and you're working with people with chronic pain, you should continually address your own biases, viewpoints with your director, supervisor, peers, and or your own psychologist. And the same thing goes if you have a disability. So it's a continual self-reflection and just looking at how you are interacting with your patients so that you can give everyone the best quality of care. I won't read all this, but Dr. Oakland, that psychologist, had said that she is especially leery when able-bodied supervisors, able-bodied supervisors go ahead and try to supervise other able-bodied trainees without much experience. Just because you've seen a couple pain patients does not make you an expert. And that leads to the next point about immersing yourself in the pain culture. So in addition to reading pain-specific journal articles and receiving pain-based communication education, all of that sort of things, visit pain advocacy websites, attend functions like this. So you're really able to understand more of the concerns from the view of people with pain and not just in medical terminology. And I also talk about this self-care for the medical professionals, but also all of us, of course. So living your values, trying to practice what you preach to try to stave off burnout. I also talk about how, remember, many patients come in stuck in a cycle of hopelessness and suffering, and it can take a while for a person to accept that they're having physical pain and move away from psychological suffering. So it's about keeping up with your own self-compassion so that you're more readily able to provide that to your patients. And lastly, all the clinical case examples that I gave, all the just don'ts, part 1 and 2, all of that was representative of one person throughout the ages of their life. And that's me. So everything I talked about, just the experience I've had with doctors and rude comments and people and misunderstandings and being too young, that's me. But you also know that I am not just my disabilities, and I'm in the double digits of disabilities, quite the high double digits. But I'm also a mindfulness lover. I'm a person with chronic pain. I'm a canine and bird mommy, 2 dogs, pug and a paw. I'm a friend, an amateur gardener, a workshop presenter, a person with multiple medical diagnoses. I'm a wife, a daughter, a doctor, and a hardcore Lord of the Rings fan. So I'm a lot more than just my pain. And even though my pain can consume my life and it's very hard, I made a promise to myself a long time ago that living in a chronic pain hell day in and day out in bed wasn't for me, and I had to do something about it. And it's hard. And it's exhausting. But I'm hoping that me being here and supporting people on a bigger level and supporting my patients can help give you a little hope that you are able to do that as well. I'd like to end with one of my favorite quotes, and that is, pain is inevitable, suffering is optional. We're going to be in pain, but we can still try to do things in our lives that make us feel full, even if they're little. So thank you so much for having me here today. I really appreciate your attention.